Hello and welcome to everyone joining us for this Xtalks webinar. Today's talk is entitled Enhancing Prostate Cancer Screening, AI, Imaging, and Clinical Innovations. My name is Corey Stanton and I'll be your Xtalks host for this event. Today's presentation runs for approximately 60 minutes and the webinar includes an interactive Q&A session with our speakers. To make the most of this session, feel free to submit questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to as many as possible. This chat box is located in the control panel on the right-hand side of your screen, and if you require any assistance, please don't hesitate to contact me by sending a message using this very same chat box. Please note that all participants are in listen-only mode and that this event will be recorded and made available for streaming on xtalks.com. At this point, I'd like to thank Quibim, who developed the content for this presentation. The team at Quibim is transforming personalized medicine by delving beyond what the human eye can see. They employ AI-powered imaging tools derived from years of intensive research to assist doctors in diagnosis and anticipating patient progression. Their solutions transform imaging data into actionable predictions, enhancing patient outcomes and driving medical imaging innovation. Now internationally expanded, Quibim is excited to introduce a new line of products focused on predictive imaging biomarker panels, ensuring continuous advancement in life sciences and provider solutions. One of our speakers today is Professor Dr. Shonit Punwani. Dr. Punwani, a professor of magnetic resonance and cancer imaging with a Ph.D. in MRI physics, serves as a consultant radiologist at University College London Hospitals. He chairs the National Cancer Imaging Translational Accelerator and specializes in quantitative and functional MRI for prostate cancer imaging. His work focuses on advancing MRI techniques for prostate cancer screening, diagnostics, and management, while also exploring in vivo prostate cancer metabolism to guide treatment decisions and reduce unnecessary interventions. Joining Dr. Punwani is Anna Nogué. Anna, as a project manager in Quibim's Clinical Studies Department, is focused on leading research projects with top-tier pharmaceutical companies, biotechnology companies, and international hospitals, as well as collaborating on grant-funded projects. The main area of oncology-related work is prostate and breast cancer. With experience in the clinical operation departments at pharmaceutical companies and CROs, as well as her technical background in biomedical engineering, she brings a more holistic point of view in optimizing medical images for more scientific projects and clinical trials. And rounding out the panel today is David Bazaga. David is the product lead at Quibim, spearheading the company's efforts in the development, validation, and deployment of healthcare algorithms used in clinical practice. His role sits at the intersection of R&D AI, business development, and regulatory teams to ensure valuable products can reach a user's clinical routine. He holds a BSc and MSc in biomedical engineering and has prior experience in AI-based medical devices and the biopharmaceutical industry. And now, without any further ado, I'd like to hand the mic over to our first speaker today, Dr. Punwani. Dr. Punwani, the floor is yours.
Okay, so I've got a bit of time really just to talk about imaging and really how it's transformed the management of prostate cancer. And I guess we are going to be moving as we go through the talks towards screening, but really a good place to start is from the very basics of what it was like before we started using imaging, and then take you through from there in terms of what the challenges are currently and how we're trying to overcome some of these to enable us to go towards a screening approach. So I'll want to start really with a bit of basic background, and then I'll talk about a type of imaging technique which is really coming into clinical practice now in the diagnostic setting, i.e. people who present with symptoms of potential cancer in their prostate, and that is called mpMRI, so multi-parametric MRI. So I'll give you a bit of a story about how that was developed and how it's now implemented. And then we'll look at the challenges that kind of remain, and in the era of having mpMRI for diagnosis in terms of avoiding biopsy, screening, and just mention very briefly about prognostication. So just start with a really basic background on what we're talking about. Prostate cancer is a really common disease, and it is a particularly large proportion of men are diagnosed with prostate cancer, second most common cause of cancer. A lot of people who get diagnosed, in fact, the majority of people who get diagnosed with prostate cancer do not die of their cancer, but we don't at the moment know which are the most aggressive cancers and how best to manage them. So we are in a developing field where we're actually trying to find the disease which is aggressive in men to essentially stop them from suffering from their cancer. It's a very common problem. In Europe, there are about 1.5 million men that are investigated for potential prostate cancer. And so it's a relatively major problem, and economically has consequences on healthcare systems. So what is your prostate? Well, your prostate sits just beneath your bladder, and you can see here the red area. It's a tiny organ, and it essentially produces seminal fluid. Over time, so this is a cut through off a prostate. Over time, the prostate essentially grows. It has several zones. This zone here at the end of it is called the peripheral zone. This zone, number 3, is called the transition zone. And as you age, this zone gets bigger and bigger and bigger, and your prostate gets bigger. And sometimes a really large prostate causes problems with passing urine because you can see the urethra goes through the prostate and the urine will have to get out this way, and it can impede the flow of urine. So many men present with urinary symptoms before they get investigated for potential causes of those urinary symptoms, one of which is an enlarged prostate, but some of them may relate to the presence of cancer. In a young man, this is a chopped out prostate. In a young man, the prostate is relatively small. It's about 3 by 4 by 2 centimeters, approximately 30 cc's. And as I said, as you get older, it tends to grow with age. And a 70-year-old man may well have a 70 cc prostate. So if we look at how people get diagnosed with prostate cancer, in the UK and in fact worldwide, we start off really before you get going for investigation currently with someone having some sort of suspicion. And as I said, one of the things that might cause suspicion is that you have problems passing urine, you may have blood in your urine or other causes, but anything which causes your GP any concern that this could be prostate related will essentially get investigated. And the first thing you'll probably do is a blood test, or certainly used to be the case that first thing you did was a blood test called a PSA test, which is prostate specific antigen. And if that blood test was abnormal, you would probably then go on to have a biopsy, and then you'd go off and decide what would happen afterwards if the biopsy was positive, whether you get treatment or whether you get watched. But everything starts at this moment in time in the UK and in most countries after someone suspects that there's something going on, the clinical suspicion. So up until very recently, and when I say very recently, I'm talking about 2019 for the UK, this is what would happen to you if you presented with a suspicion of prostate cancer. So you'd go and see your GP, and you would have a test, a blood test, a prostate-specific antigen test. After you had your prostate-specific antigen test, if it was elevated, your GP probably at the same time would have done a rectal examination to see if there's any nodular aspect to your prostate once a finger is inserted. Once you've had this, and there's potentially something that's suspected based on this being high, what would have happened is you would have had a biopsy. And TRUS here, TRUS, stands for transrectal ultrasound biopsy. So a probe, which is an ultrasound probe, is inserted into the backside. And that probe is really there so that the person doing the biopsy can see the prostate. You don't necessarily at that time see a cancer, you just see the prostate. And then you randomly but systematically sample the prostate with a number of needles which are inserted into the prostate to pull out a bit of tissue so that that tissue can then get analyzed under the microscope later to determine whether you have got prostate cancer or you don't have prostate cancer. And this was the situation really before the advent of multi-parametric MRI. What this means is that you're not targeting your needle to a specific location where in the prostate you suspect is tumor. You are sampling the prostate, hoping to hit tumor. So if you were lucky in this situation, you would probably have got diagnosed with prostate cancer. So it's a rather odd thing to say, but once you've got your diagnosis, you can go off and have treatment. What used to happen is that if you were unlucky, you may not get diagnosed, and then you'd actually go back to your GP maybe a year later because your blood test has gone up again, and you'd go round this loop over and over again until you eventually got diagnosed and you could get treated. So how has imaging changed that? Well, there are a number of reasons why you might not get diagnosed, or you might get diagnosed but not know how aggressive your cancer is. And so this is your prostate, and this is an example of a small cancer within the prostate, and you can see a needle here going in. It could sample the cancer, but because you haven't imaged the prostate in the era of having this transrectal ultrasound guided biopsy, you don't know whether this is going to be a small cancer or whether it's going to be a big cancer. So actually it becomes difficult to determine what the best course of treatment is. So as I said, you could sample a small cancer and you might sample it really well, so you think it's quite big, or you could skirt a really small, big cancer at the edge, and so you might not know whether this was a large tumor at the time that you did a biopsy. More importantly, what used to happen is that if you had cancers which were far away from where the rectum would be and the needles go in, they may never be sampled because the needles are only about 2 centimeters, and if your prostate is 5 or 6 centimeters from top to bottom, you may never hit that, or you may randomly just not hit the tumor. So up until very recently in 2019, this was what most men were having done, a non-targeted biopsy of their prostate in the hope that prostate cancer could be detected. Imaging at that point in time was really done after the biopsy, and it was really done to identify potentially where the tumor was in relation to the prostate, whether it was inside or outside the prostate. This is the sort of anatomical imaging that people would do. So I'm just scrolling through the images just to show you this is what the prostate looks like in an anatomical MRI scan. There is that peripheral zone. There is that transition zone, which is enlarged over time, and the tumor might appear as a black area somewhere within the prostate. And what your radiologist would be interested in is knowing if this is your prostate, is your tumor within the prostate? Is it popping outside of the prostate? Is it invading into any of the organs? And that's really where the role of imaging was before we got to our multi-parametric MRI stage. And then along came this opportunity to develop a new imaging technique, which essentially allowed people for the first time to visualize where the tumor was within the prostate before the biopsy, so that you can actually guide your biopsy needle to the location of potentially where the tumor is. And every other cancer up until this point, that's kind of what would happen because you want to sample the area that you're worried about. But prostate cancer, that wasn't the case until we got this technique developed to allow us to find disease. So this is an anatomical image of the prostate, as we mentioned, showed you before. There are a couple of areas here which look slightly darker. You can see one here and one here. And as a radiologist, I couldn't really tell you just on anatomical images whether that is tumor or whether that is going to be some other process going on, which I don't need to worry about. But what we do now is we complement those anatomical images with images which reflect different parts, different properties of tissue. So this image is called a diffusion image, and what it actually reflects is the amount of cellular material, how cellularly dense this particular area is. So bright areas are highly cellular areas. So those two areas I showed you before, which were indeterminate really on the anatomical images, when I look at this and the anatomical images, I can say, well, this looks like it's going to be a cellular thing, which is more characteristic of tumor as opposed to benign areas. And the other thing we did was inject contrast, which is a dye, essentially, which shows up as bright on the MR signal in areas where the vessels are abnormal. And you can see that you start to be able to pick up small focal areas which light up as you inject contrast, and that itself is telling me that the vessels in that area are abnormal, and therefore they may be more likely to be cancer in that area. And you can just see how that pops up into view compared to all the normal background tissue. So putting that all together, we created this opportunity to localize and characterize lesions within the prostate, so that when you have the anatomical images together with the cellular information, together with the vascular information, I can more confidently put that together and give you a score of whether an area in the prostate is likely or unlikely to be tumor. So 5 would be highly likely, 1 would be highly unlikely, which means that when the urologist wants to do a biopsy, they can look at these reports that are produced by radiologists and biopsy the areas, or make a decision on whether or not to biopsy, and where they do biopsy the area specifically where tumor is likely to be. So that's been transformative, really, and the national guidelines have changed in 2019 from doing MRI here for just working out where the tumor has got outside the prostate to doing MRI here, which is essentially saying once you suspect someone of having prostate cancer, the first thing that you should do, in addition to the PSA, is to do your MRI scan, the mpMRI scan, and then decide about who to biopsy. So this is a huge advance already. Something aside we should just talk about is how significant is prostate cancer? And there are different grades of prostate cancer. And in essence, it's graded by a system called a Gleason grading system, and it gives it a couple of numbers. And that is all based on what the histopathologist, when they look at the biopsy specimen, sees under the slide. And the more disordered the microstructure that the histopathologist sees, the higher the grade that they call. And this number here, the first number, is what the most common, what the most prevalent area, or what the most common thing is that the histopathologist is seeing. And this number here is what the second most common thing the histopathologist is seeing it when they look down the microscope. So not all cancer, and this is important, not all cancer is significant. That people generally with low grade, and 3+3 is essentially low grade and small volume disease, do not die from their prostate cancer. It is actually the higher grade disease that is the important disease. And why is that important to mention now? It's because actually when we want to detect disease, we don't really want to detect the low grade disease, because we don't really want to treat it, because it's not going to have any benefit. In fact, it can have harm because of the side effects of the treatment. But you do want to treat disease which is higher grade, because that is the disease that has the potential to cause mortality and morbidity. And there are various studies that have been done, and this is a study from some time ago now, which look at outcomes in men with different types of grade of disease. This is really high grade disease. The light gray is essentially showing a number of people that were diagnosed with this disease. And as we go across here is the age, and the age increases. The black is the number of people that die with their disease. So just comparing the gray and the black, you can see that if you are younger and you're diagnosed with high grade disease, you have a worse outcome than if you are essentially older and diagnosed with low grade disease, where pretty much everyone with low grade disease survives. So it's really important to build a test that is able to pick up the higher grade cancers, but you don't necessarily want to go and diagnose lower grade cancers, which actually might cause more harm than good in doing. So there were some studies that we conducted before 2019, which essentially showed that using multi-parametric MRI, we could have an improved sensitivity. So this was the trust biopsy, 50% sensitivity, so it picks up half of the important tumors, up compared with 93% sensitivity when you start targeting tumors with multi-parametric MRI. Much higher sensitivity for detecting significant disease. So that's the background. That's where we are now. That's what we do nationally, and that's what most people do internationally. You have some suspicion, you have a multi-parametric MRI scan, which takes about 30 to 45 minutes. You then have a biopsy based on what's seen on the multi-parametric MRI scan. So what is the problem now? Well, first, we still don't get it right every time. We see things on the MR scan which need a biopsy because we're worried about them, but half of them turn out to not be significant cancer. So there is an opportunity to try and do better within that. And then the second part of this is that actually a scan takes 30 to 45 minutes, and there is a healthcare cost associated with that. And actually what we want to do is to try and reduce that healthcare cost by reducing and making the scan faster and ideally a little bit more accurate than it is at the moment. It's certainly better than things were before, but we can do better overall. And then the third part of this is that actually where we are now, if you look at the number of deaths from prostate cancer in the United Kingdom, they haven't dropped despite the fact that we've had this scan now for a little while. And it is highly likely that we aren't picking up the right people at this moment in time to have the scan, because we're relying on a suspicion of prostate cancer rather than thinking about going to the general population and asking men who are asymptomatic, have no particular health problems, to come and have a scan and see if we can find the disease even before symptoms might be related to it. So I'll talk about a couple of areas that we've been developing solutions based on more advanced imaging to try and see if we can get things better than we are even now. So can we improve the ability to make a decision to biopsy? So we have a new type of imaging technique that we've been working up, and in essence, it's a diffusion type technique. As I showed you in the slides before, those areas which are bright were cellular, but with this type of technique, it's been designed from the ground up to be used for prostate, and it gives you more detailed information about the tissue microstructure. The development was based on understanding what was present in prostate cancer, producing various mathematical models, and then essentially deriving and writing the software for the technique on the MR scanners so that we were able to pick up the important parts that prostate cancer presents with in terms of histological changes. So this is a mpMRI scan for a particular person, and you can see that on the right side there, it looks like there is something abnormal here. It has this high diffusion signal. It enhances on your contrast enhanced images. So it's looking very much like cancer. But with the new technique, in addition to this, you start to get other information about the tissue. For example, here, exactly how cellular it is, or how many cells there are of a particular radius in this particular area. So it's more detailed microstructural information. So this is something that we wanted to test and see whether it was possible to use this to get a better decision about who to biopsy. And so if anyone's interested, this is the first paper on this that was written, where essentially we were able to show that this particular technique was able to discriminate between tumors versus areas which were non-tumor. So we could have made a potential better decision to biopsy. So here's just the results from that study. This is the score that the radiologist gives, 3, 4, or 5, meaning that there is something abnormal there that needs potentially a biopsy. These are different parameters that you can derive from the imaging. This is a diffusion parameter which you can derive, which is very standard, can be derived by any scanner. This is the new parameter from the new technique that can be derived. And the red bars here and the blue bars essentially show that with the new technique, red, which are the positive biopsies, actually show a different value than the negative biopsies in this trial of around 170 men who were biopsied, and irrespective of what the radiologist thinks. So if the radiologist thinks I score of 3, if I had used this technique, I could then say, yes, this is 3, but actually you're part of this red area and you're more likely to have tumor. So you should have a biopsy. Whereas if you were part of the blue area, we'd say actually you're less likely to have tumor, so you shouldn't have a biopsy. So we are bringing in new technologies to potentially make a better decision to biopsy. With this specific technology, we think we can probably avoid 90% of unnecessary biopsies from occurring. So this is being developed in trial now, in prospective trials, to determine whether what we found in this particular paper is able to, in practice, demonstrate the same results. And that brings us on to the question of screening. If we have a test that we want to use in the general population at scale, it needs to be cheap, it needs to be fast. The current multi-parametric MRI scan, 30 to 45 minutes, it needs an injection of contrast, is not fast enough, and it is potentially going to be costly to do at a population level in order to make this work. So we're looking at trying to find faster solutions. This is essentially a paper we wrote which looks at how long it takes potentially for a multi-parametric MRI scan, which is 28 minutes. And then we try to leave things out of that scan to potentially make the scan shorter. So here is a 20-minute scan, which is part of a study which was done in the screening population. And even shorter scan, which is a 10-minute scan, which is part of a different screening study, which is recently published. But in essence, we were asking, if we just reported this, what was the performance of that scan report for detecting disease compared to this full set of data, or compared to this set of data, which is somewhere in between the two? So how much information can we leave out and still get the same performance? And actually, when you start to do that, you can see here the very short scan, the less than 10-minute scan, actually has the same sort of performance in terms of sensitivity and specificity as the whole data set scans. So there's a real opportunity there to use short, abbreviated scans, which are simple and quick in a population setting. You may have seen, some of you may have seen this paper. This is the screening study which used that very short 10-minute scan and demonstrated actually that it was possible to detect disease, significant cancer in the general population when people were asked just to come along for that scan plus a PSA test. So that this study, again, you can have a look at the paper if you're interested to give more details, was done at University College London Hospital. It was really looking at MRI as an opportunity. Men were invited from their GPs, based 50 to 75 years old. It was done as a screening test with PSA. And if any of this was positive, you went on to have an NHS scan and a biopsy if needed. So just to skip through the results of that study, which kind of indicate how a screening MR might work, just look at the right side of this diagram. This is the number of men that enter that study, 303. Out of those 303, 48 had a lesion on their MR scan, that fast scan. So 1 in 6 men had a screen positive result. When they went on to have their investigations in the NHS, one thing we did was a multi-parametric MRI scan, and then those which were positive on the multi-parametric MRI scan got a biopsy. And pretty much most of those which were positive on the multi-parametric MRI after they got screened had significant cancer. So 29 men who were biopsied with this particular screening scan had significant cancer, so 1 in 10 men. And the most important thing to say about this group here is that they were not symptomatic, and half of those men did not have a high PSA. So the MR scan was able to detect disease in half of the men that were biopsy positive without an elevated PSA. So it might be a real opportunity to detect disease at scale, and that is a part of what we're going to find out soon. So what sort of disease is detected? So this is one man from that study, and you can see the large tumor here on the right-hand side. This is another man, large tumor on the left-hand side on those really fast scans that we talked about. Both of these men had raised PSA, but actually this is a man with a normal PSA density, and you can see here tumor, large, another large tumor on the right side, normal PSA. So sometimes your PSA is elevated, sometimes your PSA is not elevated, but you still have large tumor detected by this scan. So all men, as I just point out here, had this short scan, and then they went out to have an MRI scan, and only if the MR was positive did they go forward. So why can't we just get on and do this at scale now? Well, we've done a small study, and we don't know whether this is going to be the same when we do a large enough powered trial. And so we do have now funding to do a large powered trial, and it is going to essentially start hopefully in the next 6 to 10 months. And we'll try and see if we can get results which demonstrate that scanning, amongst other things, could be an approach to screening. Within the study that we published, which is the one I showed you, that approach that we've got might not work, because actually we had 1 in 6 men who had a screening scan who went on to have a multi-parametric MRI, and we can't send 1 in 6 of all men screened into the NHS. It would cause all sorts of issues in terms of delays and bottlenecks in terms of diagnostics. There was another study done by a colleague of mine where they did that shortened version, but not as short as we did, as a single test for screening in men. And with that type of study, actually what they found is that if they were making a decision to biopsy from the screening scan alone, 1 in 4 men would have cancer at biopsy, and actually 3 other men would have to be biopsied. So you have to biopsy 4 men for every cancer you detect, which again might cause issues with unnecessary biopsies. So these are still challenges we're trying to work through to see if we can do better. I'm going to skip through some of this because there are alternative ways of actually doing scanning which might be fast, and this is just one other way of doing it, which essentially, with this new technique which we're developing, you can create a map of whether there's likely to be tumor or not, just in red and green, in a 5-minute scan, as compared to the whole multi-parametric MRI scan, which takes 30 to 45 minutes. And actually, we're trialing this as well in a couple of trials to see whether it might work in screening and how good it is as a single standalone scan. So that we are trying different ways to work out whether we can do better than what we've got already. In addition to trying to develop new scanning sequences, we should link back into the decision to biopsy, and whether some of the work which we've done previously with this more advanced diffusion can help that decision to become better, so less men have an unnecessary biopsy in the screening setting. So we're developing faster scans to try and do that. And I guess the big opportunity for us really is to integrate the challenges that remain in trying to get screening implemented with the AI solutions that are being presented and developed by different vendors. And this is an opportunity to potentially triage patients who come and have a screening scan, so that actually all the normal scans don't need to be looked at. And that's a potential area that could be looked into. You could have an AI system as a second reader, because these scans need 2 radiologists to read them. Although it's very quick, it's still a cost to the NHS. And you might have seen recently how a second read breast AI was able to detect disease that radiologists missed. So there may be an opportunity to improve that. And then that question about who to biopsy. At the moment, if we implemented something, we'd probably have to biopsy 4 men for every 1 cancer detected, which may not work out. Can we use AI to help us with that decision? So there are areas of research which we actively need to do, which will take place in the next years as we go through, as part of a larger trial for checking whether imaging and other strategies for implementing a prostate cancer national screening program could work. and that's called the Transform study, which will, as I said, hopefully start within the next year. So hopefully that's given you an idea of where we were actually trying to get to. This is where we're at the moment with MRI. You have suspicion of cancer, you get an MRI, and then you go for a biopsy. But what we really want to do is to move screening into screening space, which is pre-suspicion, do your scan, decide on who you want to biopsy, and go straight to biopsy. So my final slide here is just to give you a summary of what we've said. So we've got multi-parametric MRI. It is relatively good. We're using it in people who are symptomatic. We need to move towards screening. We need a technique which is going to be as good as or better than multi-parametric MRI if we want to use it in screening. We really want a single test which goes straight to decision to biopsy. And that test will need to be fast. It will need to be sensitive. It need to be positive really only in as high a proportion of men that have cancer and a lower proportion of men that turn out to be negative at biopsy. And this is a real opportunity for new technologies to come along, and a real opportunity, given where we are with AI, for AI to help in assisting answering these questions so that we can get a national prostate cancer screening program, which is does what it says it's supposed to do, but is cheap enough to implement across the UK. Thank you. So I think over to David.
Thank you very much, Dr. Punwani, for all your insights in prostate cancer. I wanted to take it onward from here in terms of what it's the potential of AI in this prostate cancer pathway, and also give an overview on what we're doing at Quibim to actually achieve that. So just as a summary, starting from where Dr. Punwani left it, this is how the prostate cancer pathway usually looks like. So you start with patients and they will self-report their symptoms. They get this PSA blood test done. They'll go on to have this MRI. You need a radiologist to obviously look at that MRI, and if there are positive findings, they would go and have a biopsy, which would be the definitive diagnosis, and then based on that, they would follow up with treatment or watchful waiting or any other type of procedure. Now, there are two key bottlenecks with this type of pathway, and the first one has already been alluded in this webinar. The first one is around this PSA test, and the truth is it is suboptimal because it lacks enough sensitivity and specificity. As Dr. Punwani mentioned, in the Reimagine trial, they found out that half of the patients with clinically significant prostate cancer actually had a completely normal PSA level, which means that in the current pathway, these people would have gone unnoticed and they wouldn't have been invited to go and have that MRI. Similar studies have been performed in other countries. The one that you see on the right from BMJ Journal, it's from a very similar study in Canada with very similar results. The second bottleneck, we actually have it in the very, very core of the radiological assessment. As Dr. Punwani mentioned, it's only been since 2019 that mpMRI has been the routine practice. But obviously the problem has been that there hasn't been enough time to train enough radiologists to cope up with the demand of MRI scans. This obviously results in a radiologist shortage, but also there's a high inter-rated variability across different radiologists. And I wanted to actually delve a little bit more into what this actually means. What you can see here in this graph is on the y-axis, there are 26 different hospitals across the US that routinely report mpMRI for the detection of prostate cancer. And what you see on the x-axis is the positive predicted value. So the chance that when they actually call that lesion a PIRAT 3 or a PIRAT 4, they really are clinically significant prostate cancer. And you can see here that really depending on the hospital you end up with, that likelihood, that probability of a PIRAT 3 or a PIRAT 4 lesion being true cancer varies massively, really going from 20% all the way to almost 70%. And this obviously means that the care as a patient that you get really depends on that reporting radiologist. It really depends on their experience and their own level of expertise. And sadly, with prostate cancer, we still see this wide heterogeneity, where you can see that a PIRAT 3 for one radiologist may mean at 20% of having clinically significant prostate cancer, but for others that may go all the way to 70%. So obviously this is a problem in terms of the high variability in terms of patient care. The second one that I alluded to, it's the current shortage of radiologists that does not only apply to prostate cancer, but to radiologists worldwide. You can see in this graph from 2022, the gap between the supply and demand for radiologists, and that gap has only kept continuing to grow, especially after the COVID pandemic. And just to really exemplify what this actually means for patients, you can see here the 28-day target for all urological cancers at the NHS in England currently stands at 55%. What this means in essence is the fact that it takes only around 50% of cancers get diagnosed within 28 days from the moment that GP sent them to a referral. And that target at the moment in England, it's meant to be 75%. So we obviously need technology that can actually help us speed up and expedite this pathway to ensure that the people that do have cancer get diagnosed within the 28-day target. So with this situation and with this background in mind, what we have developed at Quibim, it's an AI solution called QP-Prostate that it's able to automatically detect lesions within the prostate using this anatomical and diffusion weighted images that have been presented before. We combine that information and we're able to automatically delineate, segment, and identify those lesions within the prostate. What you can see on the right-hand side of the image are two examples of tumors identified by QP-Prostate, and you see there are actually two different colors. The one on the top it's orange, and the one below it's yellow. And these are essentially two different levels of confidence or likelihood that the AI algorithm we have developed has when determining whether something is clinically significant prostate cancer or not. It is also worth highlighting the fact that this algorithm has been trained using the biopsy results as the ground truth. So only those Gleason 7 or above, those ones that actually do need treatment and intervention, have been considered positive. But the indolent cancers that you essentially don't need to really worry about, those have been considered as negative. And as has been explained before, you don't really want to treat those Gleason 6, those indolent prostate cancers, because you're probably doing more harm than good in terms of the outcomes and the prognosis that those people may have with that type of indolent cancer. In terms of whether this actually works or not, we've been conducting a number of different clinical validations, both in Europe and in the US, but I wanted to take a moment to talk about some of the analysis and validation studies we're doing in the US in collaboration with Mass General Brigham Data Science Office. And you can see here that the algorithm, when it was evaluated on a cohort of retrospective patients with biopsy-proven clinically significant prostate cancer, the device achieved a sensitivity between 90 to 95%, depending on that level of suspicion that I just mentioned. And it had an associated specificity of 38 to 57%, which is pretty much in line with what you would see on radiologists, depending on the PIRATE score that you use to determine whether something is actually a positive or not. But the important thing that we actually wanted to look at is how much could we actually be helping radiologists when we put this tool in their hands and they actually start using that as part of their clinical routine. At the end of the day, what we actually want to do is trying to enhance and really improve the information available for radiologists to perform a better clinical decision-making process. So what you see here, it's the unaided row corresponds to radiologists who did not have the output of our software at the time of reporting, and the aided row that you see are the ones that actually did have the presence of our software. And what you can see here is that when radiologists did have the output from QP-Prostate available, that sensitivity went up by 10 percentage points. So that essentially means 10% more patients were actually being able to be correctly diagnosed. And one may actually wonder whether that came at the expense of really decreasing the specificity, but you can actually see the specificity was kept at a very similar level. So this essentially means that this tool actually has the potential to bring a real, tangible, measurable clinical benefit into the clinical practice when used by qualified radiologists. And I just wanted to finish around what are we doing in terms of prostate cancer screening. And as Dr. Punwani mentioned, the answer really is we still don't know, and we still have more research to undertake and to perform to actually see which could be the most optimal pathway for an AI tool like ours to be fully implemented in combination with other clinical and imaging tests to really ensure that we have the best optimal pathway in terms of a high sensitivity and a high negative predicted value, while obviously minimizing that number of unnecessary biopsies. So this is some of the pathways that we are still starting to explore and starting to test from a clinical performance perspective. And this will obviously be followed by health economic assessment as well as patient involvement group. So that's a glimpse of what we're doing at Quibim at the moment in terms of the research and the development of products in prostate cancer. And with this, I will give the screen to my colleague, Anna. Thank you very much.
My name is Anna Nogué, and I'm project manager at Quibim. And in this talk, I would like to talk a bit about how we can use QP-Prostate and the products that we have at Quibim in clinical trials, and how we can help the pharmaceutical company. So you can just pass the slide. Okay, so how we can help biopharma companies using AI and also to improve early patient access to late-line therapy. Yeah, you can, okay. So I just want to give you an example. There's a pharma company that they have a drug for treatment of metastatic prostate cancer patients, but this drug is approved as second or third line. But is it possible to accurately predict which patients they will benefit from this therapy? Here we have a challenge. So the company told us, can Quibim create an AI model that predicts the risk of developing biochemical relapse or metastatic recurrence in localized prostate cancer using the standard of care of diagnostic imaging data, like it would be MRI, CT, or PET-CT? So that's the challenge that we have. And the solution that we are proposing and we are doing is to create an AI model that predicts metastatic recurrence in patients with localized prostate cancer by using biomarkers from the imaging that we have already and also clinical data. And we try to benefit those patients to have access to the late-line therapies. You can pass. Okay, so how we are going to do that? It's a retrospective study where we have already the images from those patients. What we are going to do is to collect the MRIs of those patients, the tissue, the diffusion, and perfusion images. And as David mentioned, we are going to use our tool of QP-Prostate to do the segmentation of the prostate, the different regions of the prostate, as we can see in that image. Also, what we are going to do is to extract the imaging biomarkers, like the apparent diffusion coefficient or the perfusion parameters. As well as David said, we are going to use QP-Prostate to do the lesion segmentation, the automatic lesion segmentation of the MRIs of the prostate. And we are going to extract the same parameters, as well as we are going to do the radiomic analysis of these images. Also, the standard of care in Spain, we have the bone scan. So we are going to use also these images to analyze them and to extract the number of counts. As well in Quibim, we have QP-Inside, that is a platform where we can also include all these images as well as the clinical information that is embedded in a clinical report form. We are going to use this information that it will be entered by the clinician. And as well with the other imaging parameters, we are going to create a predictive model, an IA radiomic panel, where we can try to distinguish which patients they are at high risk of metastatic recurrence and which ones are in low risk of metastatic recurrence. So then we can help for a more personalized therapy. We can help the patients and the clinicians to get benefit of these line therapies. So you can pass. Also, how an AI-driven solution can increase diagnostic accuracy. So I want to give you another example and another project that we are taking now in Quibim. That's a project that we are having with our relevant hospital in Spain. And in this case, what we want is to predict the aggressiveness of a clinical significant prostate cancer. In this case, we're going to use also QP-Prostate in order to segment the lesions that we have in the prostate in the MRI. We are going to extract also the quantitative imaging biomarkers from these MRIs, and we are going to mix it with the genomic data and combine it also with the clinical data of those patients. All this data is going to be from diagnosis. And we are going to create also an AI model in order to predict which ones they are going to have clinically significant prostate cancer just from the data from the diagnosis. So it will help the clinicians to stratify better the patients at the time of the first visit. So you can pass that one. Okay. Also, how digital twins can aid prostate cancer patients. We are also collaborating. Yeah, you can pass. Yeah, we are also collaborating in a project called ProCanAid, where the aim of the project is to create a digital twin for the diagnosis of prostate cancer and also the simulation of the effects of different oncological treatments. The aim of the project is to create this 4D digital twin of the entire prostate, but also we want to include the segmentation of the neurovascular bundles. It's also a retrospective study where we are going to include patients with prostate cancer and we are going to include the MRIs at diagnosis and also the different follow-ups. You can pass the slide. Okay. What we are going to create is this digital twin created with finite elements, and it's going to be based on the anatomical geometry. This anatomical geometry, we are going to have it from the QP-Prostate segmentation, as well as the lesion segmentation that we are going to have it too, using the QP-Prostate. As well as one of the aims of the project is to do the automatic segmentation of the neurovascular bundles, and they're going to be included also on this digital twin. This digital twin, it will also be included with the biopsy. So we will have information of the pathology reports, as well as we are going to have the biomarkers parameters that it will give us information of the permeability of the tissues and also the diffusion. Also important is that we are going to have information of the treatment. So we are going to have also information of the radiotherapy or brachytherapy. We're going to have the isocurve doses that they are registered in the MRI, and then they can be embedded in this digital twin. So then we can know how the tumor is evolving over the time. As well as other treatments as hormonotherapy, we will also include it using clinical parameters as PSA. You can pass this. As I mentioned, one of the aims of the project is to do this automatic segmentation for the neurovascular bundles. As you can see in these pictures, there's the regional segmentation made by the radiologist and also the predicted made by the algorithm. Why is important that? It's important because it's a tissue difficult to segment and also visualize in the MRI. And also it's important because nowadays it's important to know the extraprostatic invasion because it indicates a higher risk of relapse or higher importance of the prostate cancer. So that's something that we really need to take into account. So as we have seen in these examples, QP-Prostate as well as the AI models based on medical images can assist clinicians in making better decisions regarding patient staging at diagnosis and also selecting the best therapy in contributing in precision medicine. So thank you very much.
Excellent. Thank you very much, Anna, and thank you all three of you for that very insightful presentation. We are now ready to begin the Q&A portion of our event. And as we do so, I invite the audience to continue sending their questions or comments using the questions window chat box. We already have received some questions. I think we have time to get through a few of them today. So I'll go ahead and start off with a question. This is for you, Dr. Punwani. Given the potential for unnecessary biopsies and treatment stemming from the mpMRI results, how do you envision advanced imaging methods such as verdict or luminal water imaging changing patient management strategies?
Absolutely. So, I mean, the challenge for us is not detection. I mean, as you can see from the multi-parametric MRI, we can find lesions. The challenge for us is characterization. And so that can be done potentially with a novel MR technique like verdict, and you add that on to people who've already had a multi-parametric MRI scan to determine who to biopsy, or it can potentially be done with AI as well, and there's a real opportunity there. For the next part, in terms of avoiding unnecessary treatment, we really need to think about the complete pathway. So we need to start asking ourselves when we diagnose a prostate cancer now, and we get a particular Gleason grade, and we can see it, How do we know whether this is going to be a progressive cancer or not? So alternative strategies of management, rather than treat everyone, there's active surveillance. You can watch it and see if it grows and then decide. Or you can look at other factors that might increase the risk. And one of the things we're looking at is metabolism. Can we look at the more aggressive cancers? Are they the more metabolically active cancers? So the various aspects of that, and the AI stuff in terms of predicting based on what you see is another opportunity.
Excellent. Thank you for that answer. It's very fascinating stuff. We've got another question here from the audience. I think this one's probably best suited for David. David, this question is asking about why did you use biopsies as ground truth and not radiological annotations?
Thanks for the question. As Dr. Punwani mentioned, a lot of the times the problem with radiological findings and those PIRAT scores, it's not so much about the detection of those lesions, because those are real lesions, but it's the characterization. So the real challenge here is whether something really is a clinically significant prostate cancer. So something that on biopsy will actually be a Gleason 7 or above, or something that is below that and actually needs no active treatment. The problem when using PIRAT scores or the radiological findings, and as I showed in that graph, that variability is actually huge. So it could actually be extremely challenging from a development of an algorithm perspective to use PIRAT scores because the heterogeneity. So you can imagine if you give the same prostate with the same lesion to 5 different radiologists, you may actually end up, with a PIRAT 3, a 4, or even a 5. And how do you actually use that as a single reference point becomes extremely challenging, if not impossible. So that is really the reason why we always want to use or would like to use biopsies as the ground truth, because it's a more definitive and certainly a more precise measurement compared to those PIRAT scores.
Interesting. Thank you, David, for that. I think we have time now just for one more question, and this one from the audience I think actually would be best suited for Anna. Anna, this question is asking about which variables will be included in the predictive model for the metastatic recurrence.
Hi, thanks for the question. As I mentioned, we are going to use clinical data that we are going to have in the clinical report form, and also the imaging biomarkers extracted from the MRIs. But also, as I mentioned, we are going to have not just the MRIs, we're going to have the bonus scans where we are going to extract the number of counts. But it's true that we are going to have also PET PSMA, that it's now how we are going to diagnose the patients of prostate cancer. So what is interesting also to include these kinds of patients is that we are going to include also and extract the variables of the standardized uptake values, for example, from the PET component, as well as we are going to do the segmentation of the lesions of the CT scans, and we're going to extract also the radiomics from there. So it's not just going to be the MRIs and the bonus scans. So we are also going to use the PET PSMA and the CT scans for the predictive model.
Interesting. Thank you very much for that answer. I know our audience will appreciate it. Unfortunately, we have reached the end of our Q&A session. At this point, though, if we couldn't attend to any of your questions, or if you have any further questions, or if you're watching the recorded version of this webinar, you can get in touch with the team at Quibim using the contact info that's currently up on your screen, and they will have a chance to follow up with you after the webinar. I do thank everyone once again for participating today. I'm adding a link in the chat box right now where you will be able to access the recording of this event, and you can share this link with your colleagues so that they may register to view it as well. You will also be receiving a follow-up email from Xtalks that will provide you access to today's recording. And as we wrap things up here today, please note that a survey window will appear on your screen. Your participation in the survey is always appreciated as it does help us improve our webinars. Now, please join me once again in thanking our speakers for their excellent presentation. Dr. Punwani and David and Anna, really appreciate your time and insight here today. We hope our audience found this webinar informative, and we wish you all a great rest of your day. Take care, everyone.